Hello, Dr. Bature.
Hello, sir. Yes, sir, you are now your co-host. Can you see the poll icon? Hello?
I've not seen it. Where is it supposed to be? Not remote show meeting.
Okay, Dr. Diamond is the host. Let me claim host and then make you the host. I believe you'll see the icon. Yeah.
All right.
Okay. Host. All right. So I have the host privileges now.
Okay, so I'm trying to see where is the
Poll.
I'm trying to see where is the poll, yeah.
Under host tools, there is poll there.
Host tools. Okay, I've not seen it. Is it in the upper bar? Upper toolbar ko kasa? Okay.
Yeah.
Breakouts, share, optimize. Okay, I can't see it. Let me just continue.
Oh, so sorry.
Participant order. Okay. No problem. Maybe before I start, I would like to thank YWire for inviting me to be part of this webinar. And
So I think Dr. Diamond has something to say before you start.
All right, so fine, please.
I was actually giving our participants say maybe 2-3 more minutes to get in before we start. I don't know what you think about that, sir.
That's very fine. That's okay.
Okay, sir. So this is 9:07. We'll start in 1 minute, sir. Okay, so it's time. We can start. Good morning, everybody. Very senior colleagues and colleagues, welcome to our first academic meeting for the YOF, the Young Ophthalmologist Forum, for this session. With us to share his wealth of experience and knowledge on our topic, glaucoma progression, structural and functional assessment, is Dr. Sadiq. Dr. Sadiq Mohammed Abdullahi. He is a consultant ophthalmologist, a glaucoma specialist who had his fellowship in glaucoma in Bangladesh and Germany. Presently, he's the deputy CMAC Clinical Services, and he's the coordinator of subspecialty fellowship in NEC, Kaduna. As ophthalmologists, we know that glaucoma is a very serious issue. And apart from the glaucoma specialist, every ophthalmologist should actually know how to manage glaucoma properly and follow up the glaucoma progression, both structurally and functionally. Glaucoma is an irreversible cause of blindness, and its burden in Africa and in Nigeria is very huge. So the YOF has thought it's important that its members should be actually properly educated on glaucoma progression, because we see them every day in clinic, both structural and functional assessments. And the CVF test is a very important tool in the diagnosis, management, and also a tool in monitoring the progression of glaucoma. It's one of the cheapest equipment to get. Even in resource-poor centers, CVF is available. So for centers that don't even have OCT, CVF still remains a very important tool in the management and progression of glaucoma. So Dr. Sadiq is here to demystify glaucoma progression for us and its assessment. Thank you very much, Dr. Sadiq, for honoring our invitation. The Young Ophthalmologist Forum is very grateful. You can start, sir. Thank you.
Thank you very much for this kind introductions. And I also thank you for inviting me to be part of this webinar. It's an area that I really have interest in. So I wanted to create a poll, but unfortunately, I don't know how to. But maybe I will like 1 or 2 volunteers to answer my question. The question is simple. How often do you think a patient should have CVF per year? That's one. The second question is, who is a fast progressor? So these are the 2 questions I have. If anybody can volunteer, he should unmute himself and just tell me the answer. You can say anything you want, that's no problem. So I'm waiting. Any volunteer?
So I think for CVF, it can be done twice a year. That's 6 monthly.
Can I have somebody note you, please? Sorry.
Yes, sir.
Yes. Any volunteer?
Can I volunteer?
Area from
So we can do see.
Dr. Bature,
Okay.
you are still too senior. Can I get somebody that I don't know?
Hello,
Yeah.
Dr. Eric speaking from our state.
Okay, good, Eric.
Yes,
Go ahead.
for CVF, somebody should do at least 2 to 3 times in a year.
Okay. Okay,
Yes.
great. Well done. Great. So,
And for
okay, go ahead.
yes, sir, for the issue of progression, I think it has to be with the associated risk factor. For example, somebody that
So,
has
who is a past progressor? Who is a past progressor?
Okay.
Fast, like who
Yes,
progresses fast?
that's the
Yeah.
question, sir. No idea, sir.
All right, so no problem. Good, thank you. Anyone volunteer? Any other one?
Sir,
Yes, go ahead.
my name is David Obunnaya from High Foundation Hospital, Lagos. I
Oh,
think that based on some of our challenges in the country, that in terms of availability of tests and cost, that minimum should be once a year. If it's like a screening test, then it can be more if there are suspicions of glaucoma or if it has been some suspicion or diagnosis, it can now be more times in a year. But based on cost, availability, and all that it should be at least once a year.
yeah, well done. So what about who's a past progressor?
I'll leave that to my more senior colleagues.
All right, thank you very much. At least I have an idea of the
morning,
general. Hey, morning, number is okay. You want to say something?
Yes, sir.
Okay.
A fast progressor is a person that has deterioration in his mean deviation by -1 decibels per year or more.
Good. That's excellent. Very good. All right. Thank you very much. Let me start.
Good morning, sir.
Yeah, morning.
Yeah, good morning, sir. Thank you for honoring this presentation. So, Dr. Shembe Gabriel is my name from Benue State University Teaching Hospital. I
Okay,
will
thank you.
take the CVS, the number of CVS times.
Okay.
Well, first, I will say that 2 times to 3 times per year should be okay. But again, I would like to say that I think sometimes it depends on the stage of the glaucoma. Now, in early glaucoma, what actually is happening is that the structural damage is what is predominant in early glaucoma. And then in advanced glaucoma, there's already an established structural damage. So I think, well, if I'm wrong, please correct me. I think that the CVS should be more when the glaucoma is more advanced. It could be 3 times or even more per year. Thank you, sir. For the other question, I don't know the answer. All right, thank you, sir.
All right. Thank you very much. Everybody, that's one excellent response. Okay, maybe at the end of my presentation, we can revisit the question and talk about it again. So one thing about glaucoma is that it's quite interesting. You can be talking and talking and talking and talking for the whole day. So my topic for discussion today is structural and functional assessment of glaucoma progression. And I intend to take the presentation under these subheadings: little introduction, definition and prevalence, justifications. Why do you want to assess for progressions? What are the methods of a progression assessment? And how do you manage progression when it occurs? So we all know that glaucoma is a chronic progressive disease. And the goal of glaucoma treatment is to slow down the rate of the disease progression. And this progression has both structural and functional components. So in glaucoma, progression is the rule rather than the exception. There is no patient who cannot or who does not progress in glaucoma. What we are interested in and what we want to find out are the people that we call fast progressors. These are people whose glaucoma progress at a rate worse than -1 decibel per year. In the mean, in the global measure of mean deviation, estimated from at least 5 visual field tests. So what this means is that if somebody has done CVF 5 times and you run progression and is progressing at more than 1 point, less than, at worse than -1 decibel per year, then that person is a fast progressor. Now, within our glaucoma clinic, in your various departments, do you know the proportion of your patients who are fast progressors? I checked the literature looking for proportion of fast progressors in Nigeria. I couldn't find any. But according to this paper that I laid my hand on by Jackson et al., the prevalence of fast progressors under routine clinical care has been reported to be between 5 and 12%. And in the paper, they reported that 1 out of 8 of their patients is a fast progressor, and that is in Australia. So why are we interested in progression? We're interested in progression in order to identify people at risk of people at risk of functional disability. Whatever we do in glaucoma management, whether it's drug, whether it is surgery, whether it is laser, is to reduce the pressure so they have stability of visual fields and the patient can have now a better quality of life. Now, if a patient is a fast progressor.
Sorry, sir, please, can you put it on slideshow, sir?
Oh, sorry. If a patient is past progressor and a diagnosis is made at the baseline with a mean deviation of -3 decibel, in 9 years we develop a severe disease which is -2 decibel. And now by another 10 years, which is 19 years from diagnosis, the person will be legally blind, which is -22 decibel, according to United States Department of Social Security Administrations. That is, the patient is moving at -1.0 decibel per year. So you can see it's really important to identify those people who are at risk of progression. And another thing why we want to do progression is to evaluate adequacy of treatment. Whenever we are seeing glaucoma patient in the clinic, we have one question in mind. Is this treatment adequate for these patients? And one of the ways that we know a treatment is adequate is if we measure the disease progression and we see that it's within the acceptable limit. Your pressure can be fine, everything can be fine, but disease progress. So it will help us to stratify our patients and plan the next line of management. So how do you assess structural progression? According to consensus of all glaucoma associations, structural progressions can be assessed using optic disc retinal fiber layer photography serially, optical coherence tomography, confocal scanning laser ophthalmoscopy, and scanning laser polarimetry. Now, the first two is what concern us, and the one we are going to actually discuss. Now, in a patient with glaucoma, we know that disc hemorrhage and beta zone peripapillary atrophy are non-risk factors for progression. So if you see a patient with a disc hemorrhage, it's a pointer that the patient is likely going to progress. And then studies have shown that fundal photo is the best imaging modality to identify disc hemorrhage. In fact, in ocular hypertension treatment study, a lot of patients who had disc hemorrhage were missed until when they had fundal photography. So it is very important to do serial fundal photography if you have the facility in a patient that has glaucoma, especially in the early stage of the disease. And you can see if there is any change in B.
Hello, we can't hear you, sir.
Okay, you can hear me? Okay.
We lost
Can you
you
hear
for
me
like 10 seconds. We can hear you now.
Okay, so what I'm saying is that disc hemorrhage and peripapillary atrophy are non-risk factors for glaucoma progression. And studies have shown that optic disc imaging is the best modality to identify these anomalies. And if you have a patient that has change in their peripapillary atrophy, it's a marker that the disease is progressing. But if you have disc hemorrhage, the presence of disc hemorrhage is a sign that the disease is active. So it's good to do serial fundal photography in a patient with glaucoma. And the other thing that can be seen in fundal photo is the retinal fiber layer thinning, notching, and then other things. And then the good thing is that it has fair inter-observer and intra-observer agreements in detection of glaucoma progressions. So the next thing is additionally, also a red-free fundal photography, as you can see here, it will help you to monitor retinal fiber layer defects. You can see enlargement of existing one or the development of new one. As you can see in this photo, this is it here. You can see how it is enlarging, and see this one. So you can see it's enlarging. So actually, by serial red-free fundal photography, you should be able to pick enlarging retinal fiber layer defects. Now, OCT parameters that we need, OCT parameters in glaucoma progression, retinal fiber layer and macular analysis are some of the important parameters that is used in assessing glaucoma progression. You see, glaucoma, the primary problem, it affects the ganglion cells and its corresponding axons. So as the glaucoma progresses, there's loss of the cells, there's loss of the thinning of the neuroretinal rim, thinning of the retinal fiber layer. So if you can measure those structures that glaucoma affects over time, then there's progression of the disease, you'll be able to know. So OCT is one of the imaging things that can give you reliable and reproducible measurement of these structures that have been affected by glaucoma. Now, retinal fiber layer thickness and glaucoma progression. Peripapillary retinal fiber layer is the most popular OCT parameters used for detecting progression in early glaucoma. Now, normally, retinal fiber layer undergo attrition with age in healthy eyes at a mean rate of minus 0.48 micrometer per year if you are using Cyrus OCT, or minus 0.6 micrometer per year in spectralist. So any change on average retinal fiber layer of 4 or more, or sector change of 7 or more, is suggestive of glaucoma progressions. Now, glaucoma progression analysis using OCT is done by event-based analysis or trend-based analysis. Event-based analysis simply tells you that progression has occurred, or progression is likely to have occurred. And how does it do that? It measures the difference between the baseline and then the follow-up measurements. The difference, if it is more than 5, then it's marked as statistically significant. And then the trend-based analysis will tell you how far. It will identify progression by monitoring the slope of the retinal fiber layer thickness over time. So in essence, event-based analysis will tell you whether progression has occurred or not, where trend-based analysis will tell you how fast the progression, so it will quantify the progression. The good thing is that the machine has software to do this. All you need to do is have adequate number of tests for you to conduct the examination. Now, this is a typical event analysis report. Now, another thing is that most of these OCT machines, they give you both the event and trend-based analysis in single reports. Now, this is an example of isolated event analysis. Now, this is where to look at. Now, remember I told you that if the difference between the baseline and the follow-up examination is 4 or more in average retinal fiber layer thickness, the machine will mark it as significant and as a mark of progression. Now, it will mark it as yellow. Now, if this deviation is repeated in the subsequent examination, then it will mark it as red. So as you can see here, this is showing that there's a defect here. There's progression at this point and at this point. Now, this is the normal report. In this one, you can see there is event and the trends. Now, if you look at this, it tells you the rate of the progression, minus 5.4 plus minus 1.4 micrometer per year. So the trend will tell you how fast the progression is going. Well, this one will tell you whether it has occurred. So we need the two. They are complementary. Now, what about macular parameters? We know that there is high density of ganglion cells in the macula, and therefore macular thickness are important for monitoring glaucoma. And these are the macular metrics. It includes the macular thickness, macular retinal fiber layer, ganglion cell layer with inner flexiform layer, and ganglion cell complex, depending on the OCT machine you have. Now, this is an example of progression analysis based on macular metrics. Now, you can see this is the ganglion cells. The nomad is donut shape, but you can see here there's lots of the donut shape here. So this is the baseline, and this is the follow-up. So you can see, and this is the deviation map. This is where you see the defect. This rate is the defect, and you can see how it is enlarging here. And this is particularly important in early disease. Now, this trend analysis, if you are using TopCon, and this is what you get. And this is a trend analysis of the ganglion cell and ganglion cell plus plus. What about functional progression? Again, according to all Glaucoma Association consensus statements, functional assessment is assessed using standard white-on-white automated perimetry with a fixed texting matrix covering at least central 24 degrees. And then, so what it means is that if you start with 24, every time patient comes, you have 24-2. You can't do 30 today, tomorrow you do 24, another day you do 10. If you start with 24 and 30, then you have to continue with 24, if that's the one you started with. Or if you started with 24, then you have to continue with the 24. 10-2 strategy has no facility for progression analysis. It's either 24 or 13. And then you have to perform sufficient examination to detect the change. And that's where my question is, how often should patient have CBL if the patient has glaucoma? Now, according to World Glaucoma Association, patients should have 2 baseline in the first 6 months, and then 2 others in 18 months. Now, like, this is not this is not cast in stone. It's not it depends on many factors. Now, if patient has advanced disease, he may have some baseline of 3, more than 2, and then other ones the patient can do 3 for a year. In my practice, I do CBF and OCT every 6 months. Again, visual progression analysis should be based on event or trend analysis, and the meaning is the same. Event, it determines the difference between the baseline and the follow-up, and when it exceeds a set threshold, then the machine will plug it up as abnormal. Trend-based analysis, it also determines the rate of the progressions. Now, this is the report of event analysis. Like I told you, in event analysis, it does point-wise assessments. Every point will be assessed from the previous level to the follow-up level. Now, if you can see in this one, you can see some triangle here. Some are shaded, some are half shaded, and some are empty. Now, this is the progression analysis. This is the progression analysis. And you can see here, there's definition for this different type of triangles. As you can see here, when it is completely filled like this one, it shows that progression has occurred in 3 consecutive readings. When it is half full, it means there is progression at this point in 2 consecutive tests. And then it now gives you the overall assessment, possible progression or likely progression. Possible progressions when the progression happens in 3 consecutive readings. So from here, by just looking at this, you will see that, oh, there is possible progression or there's likely progressions. And you can identify the points at which progression occurs. Now, in normal, this is what you will see. You will see both the trend and the event. Now, in this trend-based analysis, it gives you the rate of the progression. You can see here, minus 1.5, plus minus 4% per year. So you can see this is a past progressor. So trend will give you the rates, while event will tell you the progressions. And you can see in this one, you can see progression had occurred around the central area. So what happened if you document progression? According to European Glaucoma Society, when progression is established, you need to reestablish the target IOP. We know that at the beginning of a treatment, we have a target pressure for a glaucoma patient. Now, if you demonstrate progressions, you have to reevaluate after 3 to 6 months. Now, so if there's progression, you set a new target IOP. If there's no progression, continue your follow-up after 6 months. Everything's stable, reevaluate 3 to 12 months. But if there is progression, you set a new target pressure. Now, setting a target pressure and how to achieve it is something different. Now, this is a very important paper, Detecting Progression in Mild, Moderate, and Severe Glaucoma, current opinion, that was published in 2023. They review all the literatures that assess glaucoma progressions. And I like how they categorize it depending on the stage of the disease, whether the patient has mild disease, moderate disease, or severe disease. Now, if the patient has mild disease, which they define as optic nerve head changes without damage, or HPA classification using mean deviation of less than -6 decibel. So when the disease is early, retinal fiber layer thickness, ganglion cell inner plexiform layer, CVF, disc photography are all indicated. And more especially, like Dr. Gabriel said, retinal fiber layer, structural anomalies are the major problem in the early stage. And that is why there is the relationship between structural function relationship in early glaucoma is usually non-linear, because a lot of structural damage will occur without detecting it on the visual function. And that is why one of the important things that you need to look at when you're assessing glaucoma progression in patients with early diseases, don't rely on the colors only. You need to look at the absolute numbers. Sometimes everything will be green, where you see one eye is 100, another eye is 95, sorry, another eye is 90. So whenever the difference between the two eyes is greater than or equals to 9, then you have to be suspicious of glaucoma, even though everything looks green. And that is the so-called green disease. And then again, we also need to be aware of the red disease. Some form of retinal fiber layer thinning may be caused by other pathologies, especially those that affect the signal strengths, like corneal opacity, vitreous opacity. Any media opacity can actually lead to thinning of retinal fiber layer. Now, in the moderate disease, retinal fiber layer and CVF 24-2 are indicated, and more especially, you start looking for the central field to see if you can pick any central involvements, because we know the importance of central involvements in patients' quality of life. In patients that have severe disease, also be careful of what is called flow effect. Flow effect is a situation whereby when retinal fiber layer starts to become decreased, when there's thinning of the retinal fiber layer, at certain level, the machine cannot pick posal deterioration. And that's not a biological parameter, it's actually a technical limitation. Every machine has a minimum thickness of retinal fiber layer below which further progression cannot be picked. And that is why, so for different machines, they have their own different values. And that's why you cannot compare glaucoma progressions of using printouts from different machines. So in advanced disease, there is this issue of flow effect, and it's more in retinal fiber layer. But in ganglion cell layer, it's stated that it's, although there may be flow effect in the circumpapillary, peripapillary retinal fiber layer thickness, but still in the macular retinal fiber layer thickness, progression can still be detected. And that is why some people argue that you can use OCT, but the macular OCT in advanced disease. So I have a little case to share with you. This is a 20-year-old diagnosed with glaucoma. The patient was placed on 3 anti-glaucoma medication in 2019. But when I examined him, the IOP was normal. He was already on drug anyway, but the CBR and OCT were normal. So I stopped the medications and then monitored the patient. Now, this is the patient's OCT. You can see from 2019 to 2025. Everything appeared to be normal. And then on the left eye also, everything is stable. There is no defects. This is OCT. This is top con OCT. This is where to look for the defect. So this patient was previously on 3 anti-glaucoma medication, but we stopped the medications and monitor the patients. The pressure has not gone up, and the retinal fiber layer remains stable from 2019. Another case is a 47-year-old female patient diagnosed with right eye primary angle closure glaucoma, a left eye primary angle closure suspect in 2020 during COVID period. So she had LPI, but upper surgery she rejected in the right eye. Now you can see this is a CBF using octopus. So you can see she has progressed, but often she repeats surgery and she's been managed on medications. So actually, progression can help you reduce the incidence of overdiagnosis and also under treatments and even over treatment. So in summary, assessment of glaucoma progression is an integral component of the disease management, and method of the assessment depends on the stage of the disease, and it helps us to identify patients at risk of visual disability. Thank you very much.
Thank you very much, sir, for this eye-opening presentation. It has actually let us know that glaucoma is not just one CVF and management commences. We need to follow up. We need to monitor progression. CVF is not going to be done alone. We also need to add the OCT component and also follow up progression. So let's move to our listeners. Any questions, any remarks, anything you have to say about the lecture we just had now?
And thank you very much, sir, for the enlightening presentation. Please, when you were trying to explain the OCT, the donut in macula, you know, your pointer, I wasn't seeing your point, and I think every other person, somebody else complained. Please, I didn't appreciate it, the donut sample. If you can go back to that place again, please. Thank you.
Okay, any other question, remark? So that we can just take all at once.
Yes, please. Thank you, sir, for the presentation.
Please go ahead.
Yes, sir. Please, thank you for the presentation again. Please, can you go over the definitions again that you gave about the progression and the values for both the OCT and CVF? And then I wanted to ask if it is the same depending on the machine you use, like the Octopus versus the Humphrey and the different OCT machines, because some of them don't like the...
Where this fellow is. Sure, you have gone and played very well. You've gone and played very well because
Please,
that
can you mute your mic if you're not talking concerning our presentation? Thank you.
Okay, thank you. So I'm asking particularly because there are some OCT that don't map like the ganglion cell inner plexiform layer. It doesn't map it like that. Some of them just, map some other, like just ganglion cell or just some other thickness that was measured. So I wanted to know if it's specific to the machine you're using or if it is the same across all the machines. Thank you.
Sorry, before we take next question, let me answer this too, so that I will not forget.
Thank you, sir.
The first question is about the donut shape. You see, in OCT there are two shapes that we need to be looking at. One is we're looking at the optic nerve and peripapillary retinal fiber layer, and they're also looking at the OCT macula. So we need to know their normal shape. Now you can see this one that I'm showing. It's looking like what? Butterfly. So the normal retinal fiber layer. Okay, let me see this one.
Mommy, it's a bubbly cat.
Okay. Now you can see this patient now. This is our patient that we stop the medication and monitor as a normal OCT. You can see the butterfly shape here. If glaucoma is there, you start losing that butterfly shape. Now, look at this one. You can see, look at this one. There's lots of the butterfly pattern. So it shows you that you're having some defect there. So that is concerning the peripapillary retinal fiber layer thickness. Now, the other one now is the ganglion cell. Now, the normal shape of the ganglion cell is donut, like this one now. You see this? donut shape, this one now, donut shape. Now, this is supposed to be round, 360-degree, like the normal shape of donut. And then the color should be also red here. Everywhere should be red. You know, like this green side, you see there's some red here and some yellow. So, but if you can see here, there's lots of that donut shape. It's not complete. And you can be here, it's even lost here. So that's what I mean. So when you look at the ganglion cell layer, the normal should be donut shape. Now, going to the second question of whether the OCTs, well, I'm used to two types of OCT. One is Zeiss. The second one is Topcom. All of these OCT machines map ganglion cell the same way. You will see the donut shape and all that. Now, with regards to the type of the CBL, now, I'm used to also two types of CBL. One is Humphrey visual field. And this data, this is, you can see this definition. Past progression is on eye with glaucoma exhibiting less than -1.0 decibel per year, decline in the global measure of mean deviation estimated from at least 5 visual field tests. Now, I got this from the literature. This is the paper. And they also got it from another study. But I know that standard CVF machine, Octopus, and Humphrey visual field, their level of there's a strong correlation between these two machines. But other machines that we have now available, I really don't know. So, but this is the definition based on that, and that's the machines we use. But I know there are so many companies now of CVF machines, so those ones I really can't say. So I can take more questions if there is any.
Okay, thank you very much, sir.
Yes,
The
I
other
have a
questions
question,
are
please.
on the chat box, and I'm going to read. So thank you, sir. In the definition of progression, is it 5 CVF done in 5 years or 6 monthly? Thank you, sir. Please kindly clarify the meaning of GCL plus and GCL plus plus, which is seen on the TopCon OCT machine. And okay, so we can take the other presentation, the other question too.
Let's start with the last one now. You see, GCL and GCL plus plus. Sorry, let me see this. This is my presentation. Okay, so when I'm talking about macular matrix, you see, if we're talking about the peripapillary matrix, you're talking about average retinal fiber layer, superior, inferior, temporal, nasal, and all that. Now, in the macular OCT, you can have the macular thickness, the whole of the thickness of the macula, which includes the retinal fiber layer, the inner plexiform layer, and the ganglion cell layer. Now you can have, so in this, so you can see here, ganglion cell complex is retinal fiber layer plus ganglion cell layer. Now you can see here, ganglion cell layer with inner plexiform layer is GCL. Well, the complex is retinal fiber layer plus ganglion cell layer plus inner plexiform layer. Now you see all this thing they are trying to do is that they are targeting the ganglion cells. We cannot assess ganglion cells, but we can try to see if we can assess the axons coming from it, you know, and all those ones. It's just this one, they're just surrogate of what we are targeting the ganglion cells, but nobody can go and count the ganglion cells. But we can see if we can assess the we know that the highest concentration of ganglion cells in the macula. So what about all the axons coming from it? And that's what this one is trying to do. So you can see in this one, GLC plus simply ganglion cells plus this one now, okay. So it's simply ganglion cell plus inner flexiform layer. Now ganglion cell plus is ganglion cells, inner flexiform layer, and retinal fiber layer. That's the difference. So which other question? Hello?
Hello, sir.
Hello, can I speak? I have a
Yes,
question.
go ahead, speak, ma. Go ahead.
The second question I did not answer. What is it?
The second question is asking progression of thank you, sir. Is definition of progression 5 CVF done in 5 years or 6 monthly?
Okay. So actually now the recommendation by World Glaucoma Association is you need to have 2 baseline. If a patient has advanced disease, you should have 3 baseline. And why do we need 3 baseline in a patient with advanced disease? Because there's what is called short-term fluctuation and there's what is called long-term fluctuation. Short-term fluctuation is that you can do CBF now, I repeat it, and have different results if patient had advanced disease. Where long-term is inter-visit variation. You do CVF today. After 1 week, you repeat CVF. You have a different result, even though no progression had occurred. So in patients with advanced glaucoma, they tend to have both effects, the short-term and the long-term. And if you are used to requesting for CVF in glaucoma patients, you can see that. So in patient that has advanced disease, you are advised to do baseline 3 CVF before you now started doing 2 tests yearly. So the baselines, to establish the baseline, and then thereafter you do it after every 2 years. But if the patient has no advanced disease, you can do like they recommended 2 CVF in the first 6 months, and then in the subsequent 18 months you can do 2 CVF. And then in a patient that demonstrates progression, if I've done a CVF 2, 3, 4 times and then it's demonstrate progression, then you can do it more frequently, maybe after every 3 months. You can do even up to 4 times if the patient is a fast progressor. So the definition is not duration wise, but rather the number of CVF. So,
Excuse me?
Yes.
Thank you, sir, for the presentation. So, sir, maybe your last statement now maybe sort of answers my question. You said it's not about the duration of the tests apart, but the number of the tests that have been done. Because like in the patient that was stopped from medications and monitored for 5 years, so I was wondering if we have to wait to do it like yearly, then, and we could also do it like based on the WGA criteria, that is due to for the baseline and then due to for the next 18 months. So I thought it would have been easier for us to pick up progression rather than be doing it annually, and then we might risk progression if we prolong the time, make it annually. So I was just wondering, which one is it? Must you just have to use what is available, or it's better to follow the guidelines, since the guideline is saying up to You repeat by 18 months, you should have 4. And then possibly by the second year, it means you should have 5. And then you can actually assess progression. But like for this patient that you mentioned, it's over 5 years. So I was wondering, this one, we are lucky she didn't progress. But what if somebody is actually progressing? Thank you, sir.
So Dr. Man, do you mean this one or the other lady or this one?
No, this one, sir, you see the results are for like 4 years, 2019 to 2025.
Yeah, 2019, 2020. There's no 2021, but we have 2022 here, and then no 2023, 2024, but we had 2025. So you can see this is severe structure because it's early disease.
OCT,
We know that structure is more important than functional assessment in a patient with early disease. And then in addition to that, you also need to, you don't rely on the machine 100%. You also need to look at other factors. Does the patient has other risk factors for progression, like the IOP, the corneal thickness, family history of glaucoma, family history of blindness? When all these things, when you take all these into considerations and the patient has doesn't have any one of those things, then you can actually, you don't have to do it as frequent as somebody who has family history of glaucoma, thin cornea, pressure is borderline, stuff like that. And then sometimes some of the patients may not come back, but you can see somehow when you make it a practice that the same way that if a patient has diabetes and is going to see endocrinology, the person that can do fasting blood sugar, do glycosylated, do renal function test. That's how we need to manage glaucoma too. Patient is coming, do CVF, do OCT. Let me see the result. Patient has done 2, 3, 4. Instruct your technicians. Once patient has done 2, 3 tests, give me progression. So the technician will get used to it. Immediately they see patient with 2, 3 results, they will print his follow-up result and then the stamp it. So you are right, Dr. Mariam, if the patient has defects, 1 yearly is too long. Where the patient has no defect at all, then you can actually do OCT once a year.
Okay. Okay, thank you, sir.
Thank you very much, Dr. Sadiq. We're very grateful. I don't think we have any more questions.
I have
nothing on the chat box.
I think we do. I have a question.
I have a question. So, sir, I want to ask, sir, that I want you to clarify when you were talking about people that are likely to progress, that when the mean deviation is less than anything -3. So, but I want to clarify that what should be the mean deviation for diagnosis of mild glaucoma? And then when you were talking about the fast progressor also, you made mention that anything, any mean deviation of less than -6. Does that mean any patient coming in with maybe a -3 mean deviation at baseline, and then when you are repeating the CVF, and then the mean deviation is now like, say, -7, can that be also classified as a fast progressor?
All right, the next question, please. The next question and the last question, so we can round up. Thank you.
Okay. All right. Thank you, Ma. So my question is this. I want to print a clinical scenario that I've often seen. Now, somebody comes to the clinic. Yeah, somebody comes to the clinic. You do your fundal examination. You are seeing features of glaucoma, and then you do the CVF. It's in agreement with the fundal findings that you have. Now, this person leaves the hospital, goes to another place that there's an OCT. He does the OCT, and then the OCT is saying that there's no glaucoma. I've seen those kind of patients repeatedly. And then as a doctor now, you are just, the person is, sometimes they're even doubting you. Did you really see this glaucoma? And then, I don't know, in that kind of scenario like that, what do you really, how do you go ahead in managing that kind of patient? Because he's already doubting you, because he goes
Thank
to
you.
probably a center that is more sophisticated. And this kind of thing happens commonly with people that have, from my own experience, people that have early glaucoma, where structural damage is the main thing that is going on. And the OCT say no glaucoma. So how do you go on with that kind of a patient?
Thank you very much for this question. This is really an important questions. I've seen many patients who had surgery, some in Nigeria, some outside Nigeria, and yet when we do OCT, CVF appear to be normal. This typical example of the patient you're talking about, like this one now. This is my patient. That's a typical example. This one now, OCT normal, but by the time I saw him, he and his mother were all on 3 anti-glaucoma medications. I didn't report the mother's OCT, but it's basically the same thing because they come to hospital at the same time. So what I want to advise you is that, you see, we don't manage glaucoma with emotion. We manage glaucoma with facts. And you don't be in a rush to start patient on medication until you have impeccable evidence that the patient has glaucoma. And one of those evidence comes from two things. One, detailed clinical evaluation of the optic nerve head. Put OCT aside, put CBF aside, examine the optic nerve head. How is the neuroretinary? What about the isinthrol, for example? Spuro and imperial are the most important things to look at. If there is no violation of the isinthrol, the imperial rim is still bigger than the superior rim, and the pressure of the patient is normal, and you have done OCT, OCT has told you that it's normal. So don't treat yourself, because if you go ahead and you are treating yourself, you don't have evidence to prove that the patient has glaucoma. It's always good to wait and establish your diagnosis before treatment. Now, CBF has a learning curve. I have seen patients with mean deviation of -16, -14. But when you repeat it, everything becomes normal. So that's why you need to have baseline, 1, 2, 3 baseline. And in interpretation of progression, we give a lot of emphasis on the baseline. If your baseline is poor, then every other thing will be affected. So sometimes you can change baseline. In the machine, you can just click change baseline, you take another test. So that is it. So baseline is very important. So don't treat until you have evidence, prove that yes, glaucoma is there. And why is it important? Because treatment is for life. Once you start treatment, it's for life. There are those that you think, you see, one thing about glaucoma, if it's there, it will be adding up. There will be family history, pressure may be borderline, cornea may be thin, optic nerve head may be equal, the superior and inferior might be equal. You'll be seeing things adding up. But when you see only one factor, you really, those are the patients that we call glaucoma suspects. And you need to really follow them up. Now, the other question is, you see, the definition of progression is not the difference between the first and the second, but rather slope of a graph. You need to have a series of tests. It's not you that you look at mean deviation today is -3. Next time the patient come is -4. That's not how it is done. It's the machine that will make that calculations for you. And for the machine to do the calculation, they look at the mean deviation at every point, and then assess and tell you whether progression has occurred, which is event, whether the progression is, it will not tell you the rate of the progression. So it's not really, in fact, according to the World Glaucoma Association, they discourage people from comparing one CBF to another. They encourage people to use the software that is inbuilt in the machine. It makes everything easy. And even as that, you have to correlate with the clinical findings. Does this progression real? So if you have progression today, you have to confirm it in the next visit. If it is there, it's progression. Now, another thing is that you have to confirm, is this progression from glaucoma, or is the man developing media of RC like cataract or something? Or if it is, I have seen a patient who has macular scar, who has a scar in the retina, and that is giving him retinal fiber, focal retinal fiber layer thin. So you have to, is is the progression genuine? This can be proven by repeating the test. The second, is it due to glaucoma? You have to answer this question. So it's really not the difference between the MD of first and the second visit. It's aggregation of readings. So I don't know how to answer. I have seen one question. Let me answer it. Somebody asked the difference between green disease and red disease. This is very common in OCT. Now, green disease simply means that somebody has, OCT is a game of colors. We have green color, we have red color, we have yellow, I think. Now, green, everything normal, red abnormal, yellow borderline. Now, in the early disease, we know that the retinal fiber layer are not lost at once, everything zero. No. Maybe initially, the one eye is 120, for example, micrometer. But the other eye is, let's say, 100 micrometer, but it's still within the statistically normal range, even though it's reducing. So you can see in the OCT, the color will be green, but the actual number has reduced, but it's still within the statistically acceptable range for the patient's age and gender. So that's the green disease. The disease is there, but it's appearing green. Now, for the red disease, anything that reduces signals will reduce retinal fiber layer thickness. If somebody has corneal opacity, the most common one is cataract. If somebody has cataract, if you do OCT, every eye will be red. So you think that, this is glaucoma, OCT is red, OCT is red, it's glaucoma. So you have to be sure that. So that's called the red disease. So now this is another question in another scenario for the doctor that asked the first question. So you can see OCT everywhere is red, but when you do CVF, it's normal. You understand? So this is the green disease and can be explained by any form of media opacity, which can reduce the signal strength of the machine.
Thank you very much, Dr. Sadiq.
Thank you very much, sir. Can we get this slide?
It has been a very enlightening conversation. We are grateful. We have been more enlightened than we were before we got in. Special thanks from the executive of the Young Ophthalmologists Forum and the members. We are really very grateful that you actually took out time from your very busy schedule to take us on this. But like Oliver Twist, who asked for more, sir, when we have other topics that we need more enlightenment, we are going to call on you, sir. So please do not.
I think on important topic that we need to find time and discuss is artifact in OCT.
Fantastic. Fantastic, sir.
Artifact in OCT, yeah, because a lot of OCT is becoming very, very common now. Very, very common. Almost everybody is OCT, but there are some artifacts that can affect your reading that can, So maybe we'll have time and talk about that. No interpretation of OCT, the artifact and how they affect reading.
Okay, sir. Thank you very much, sir. Consider that done because the academic committee is already taking notes of artifacts in OCT. So my name is Diamond Tonye Obene, and I'm the moderator for today's discussion and also the chairman of the Young Ophthalmologists Forum. So I say thank you to our very senior colleagues for actually making our time to come and get enlightened. Thank you very much. And keep your space open because we'll invite you very soon again. Thank you.
Thank you for having me. Have a wonderful.
Thank you, sir.
Thank you.